Good morning, Dr. Shah, and thank you for taking this opportunity to talk to the OI audience. I will leave it to you.
Great, Ingan, thank you very much. And I'm sorry I couldn't be there in person, but through modern technology, at least virtually, we can share information, and it's really a pleasure to be a part of your meeting. Thank you. Well, I was tasked with talking about osteogenesis imperfecta, specifically a spine problem that results in the upper cervical spine and brainstem area called basilar invagination. And you can see on the MRI scan on the right that these problems can become quite severe when the head settles on the cervical spine and causes problems with the base of the brain and upper spinal cord. I don't need to mention to this audience the issues that we see with osteogenesis imperfecta. With increasing severity of disease, we see asymmetric growth, and with increasing severity of disease, you see increasing severity of spinal problems. I will direct you to an article that we wrote in the Journal of the Academy of Orthopedic Surgeons in 2017, which outlines and reviews all of the spine issues that children and adults with osteogenesis imperfecta can develop, and gives you some guidelines for screening, evaluation, and treatment. But we only have time today to talk to you about basilar invagination. What is it? Well, we know it's a migration of the upper cervical spine and the odontoid, which is the C2 peg, into the base of the skull. And obviously that creates a problem for the brainstem and the cerebellum, which get compressed by this problem. It can result in flow disturbances of the cerebrospinal fluid, cranial nerve deficits, even sudden deaths in some cases. And you can see it in many different bone softening conditions besides OI, like rickets, Paget's disease, rheumatoid arthritis, and some of the other skeletal dysplasias. Basilar invagination in OI was described many years ago by Salance. He thought that about a quarter of OI patients got it. Type 4 OI and those with dental problems were most commonly found in his article, and over half of these people were symptomatic, and we'll get to the symptoms in a second. He did recommend delaying their sitting posture so that their head wouldn't impact on their cervical spine until they were about 18 months old. However, some of the more contemporary evidence points to a higher incidence in the type 3. Now, I know Jana is going to go over some of the criteria and the definitions for BI, but briefly, platybasia is a flattened skull base with a basal angle of more than 145 degrees. Basilar impression means there's upward infolding of the foramen magnum ring into the skull, which makes it look like a mushroom. And basilar invagination, the most severe form of these three entities, means the odontoid process is protruding into the intracranial space, into the brain, penetrating the foramen magnum, which is the small circle where your spinal cord and brainstem will exit from the brain. So the X-ray on your left shows platybasia, or flattening of the skull base, and the MRI on your right shows the odontoid, which is this peg, impacting into the brainstem. Normally, this does not look like a question mark. Normally, it's quite vertical. And here's the cerebellum. But most importantly, this signal intensity here shows a syrinx in the upper spinal cord. And that's from a cerebrospinal flow disruption because of all the compression. But these are the more severe forms of basilar invagination. We've seen many reports in the literature. Anywhere from 25 to 37% of OI patients have some sort of craniocervical deformity, as you've heard with the previous speakers, with basilar invagination or impression occurring in about a quarter and flattening of the skull base about the same. However, 44% of patients have basilar invagination, according to the classic Menendez article in Iowa, and many of them have hydrocephalus, which is water on the brain, and syringomyelia, which is that small syrinx that I showed you in the previous slide. The incidence or the number of people with it increases with age. So as you get older, you may develop basilar invagination. And in younger patients, if they were studied, they would have a lower incidence. And we think the prevalence is related to the severity of the OI. The worse the bone, the higher the presence of basilar invagination. So much so that we have recommended screening all of our patients with severe spinal deformity for basilar invagination. Unfortunately, bisphosphonates have not been shown to have a significant effect at preventing BI. What is the etiology? I think Jana will cover that in some more detail, but it's just a failure of the weight-bearing parts of the skull, the occipital condyles and the cortical bone at the base of the skull is not able to support the weight of the brain and the head. You get small microfractures at the cerebrovertebral junction, and it's aggravated by early weight-bearing. But we don't understand, why don't all patients get basilar invagination if it was so common? But maybe we don't know. Maybe we're not looking at everybody. And only a few become symptomatic, fortunately. And Salance taught that 30% of them with the type 3 and type 4 have BI, but only out of those 30% who have it, only 1/3 are symptomatic. I think this is the most important thing and information to share with you. Because it's such an insidious condition, what are some of the signs and symptoms that you get with BI? And I've summarized 2 articles out of the neurosurgery literature showing you what the relative incidence of these signs and symptoms are. By far, headaches are the most common. That's an relatively common symptom in any sort of condition. So let's move down the list a little bit. A cranial nerve palsy, that is a symptom of weakness, either in the facial nerve, abducens nerve, which controls your eye movements, maybe the glossopharyngeal nerve with your tongue and speech, that a neurologist or spine surgeon can screen you for. Dysphagia means you can't swallow properly. That can be quite common. Hyperreflexia means your reflexes are a little bit jumpy. That is a sign of myelopathy or compression of the spinal cord. Quadriparesis means that you have weakness, especially in the arms more than the legs. Ataxia is a very unsteady gait, and nystagmus is a rapid eye movement when you're provoked to look to the right and quickly look to the left. So these are very specific things that we can do very quickly in the office, ask about some symptoms, check for some of these signs, and then develop a criteria for someone who might be at high risk for BI, and then perform some of the screening tests. So who do we actually screen? We recommend, as the literature also points out, a lateral X-ray of the cervical spine and skull in all OI patients before they start school. This will tell you very quickly if you have platybasia or flattening of the skull base, and it'll tell you also very quickly if the base of the odontoid has already penetrated into the skull. Now, sometimes I agree that these X-rays are hard to interpret with soft bone and the shoulders are in the way. So MRI is the next best test, perhaps the best test, after an X-ray to really look at whether someone has basilar invagination. And the diagnosis can be made based purely on MRI scan. However, some children need to be sedated. The test is very expensive and not readily available in every office. So we say, get an X-ray real quick. And if you're suspicious after the X-ray or some of those previous symptoms and signs, then to get an MRI scan of the brain and cervical spine. And you can repeat the imaging if they have BI, but they're not symptomatic, but then many years later they become symptomatic. And the definitions on the X-ray and the MRI of basilar invagination vary. And that's why Jana is going to spend some more time describing to you what some of the definitions and what some of the criteria for a hard diagnosis on X-ray. But I think because it's complicated, it may bear good information to repeat. So basilar invagination was defined as the dens, or that peg, extends above McRae's line. Here, we've indicated McRae's line in yellow. And if the base of the dens isn't past this line, that's okay. So this X-ray is fine. And again, if the dens, another definition is if it occurs before Chamberlain's line. So the red dot is not above this line, this X-ray is okay. And these are some of the criteria for diagnosis. And then basilar impression is that the dens occurs above McGregor's line. So all of these lines are chosen for different landmarks that are available to look at the skull, and all of them may have different implications. This is a diagram in a pictorial format on your right, and you can see how many different lines different physicians have described. And then you try and correlate with that X-ray on the left, and you really can't make out some of these landmarks that are so nicely outlined on the drawing. So because the landmarks on the X-ray are difficult to identify, we think that MRI is the next best test. So the next series of pictures are MRIs with various lines, and you see it's much easier to look at an MRI scan and draw these lines and become much more definitive about the diagnosis of basilar invagination. So this is a patient with headaches and neck pain as his primary complaint. He had a very mild form of OI, but has very significant basilar invagination. And this is his dad's MRI scan. And he had become more symptomatic as he got older with that unsteady gait and difficulty doing fine motor control movements with his arms, and subsequently underwent surgery. Now, in contrast, these are two patients with very severe scoliosis and severe OI type 3 who don't have basilar invagination. So why do some people with mild OI get it, and why do some people with severe OI do not get it? We just don't quite understand that at this time. This is a classic article from the neurosurgery literature. They recommended a ventral decompression. That means going in from the front through the jaw. This was very complicated, very intensive surgery, followed by a posterior procedure to stabilize the skull on the cervical spine. They reported many complications and a lot of long hospital stays and issues related to surgery. And at the end of it, they stated that the benefits remain unclear for patients who don't have symptoms but just have the x-ray. So they definitely advocated not doing surgery for people who don't have symptoms. These are some of the pictures from the article. The surgery would go through the mouth, and as you can see, would be very complicated. Fortunately, we now have very different approaches to treat this problem in patients. Here you can see that the dens has been decompressed or burred out and has relieved pressure on the spinal cord, resulting in better alignment and alleviation of those symptoms. But here's how the surgery can be done now in modern days. Rather than having to go through the mouth or split the jaw, we can use minimally invasive procedures through the nose or through the mouth under anesthesia, which can just attack the issue of the dens compression and not have to undergo very intensive surgery. So this is called a transnasal approach or transoral approach, depending on the severity of the condition. This is showing that that approach is possible because the trajectory is very applicable. And so the treatment is indicated by how severe the symptoms are. You may need a decompression, that means taking away the bone, or just a fusion. However, we have looked to the Korean literature to look at an alternative method that is quite innovative and especially applicable to children, in which we can use traction and actually lift the skull off the cervical spine and not have to do anything in the front to do the decompression, because the decompression is done indirectly. So this assumes, and we have to test, that the vagination is reducible. So here we would just do an indirect decompression and fuse the back of the skull. That involves what's called halo gravity traction. We apply a halo to the patient's head and progressively over weeks add weight to lift their skull off the cervical spine. And you can see that even for severe basilar invagination, this can become quite effective. But in order to keep the skull up and the pressure off the brainstem, we have to use spinal instrumentation and a fusion to achieve a long-term result. And this has been quite successful for us. So here you see a CT scan on the left showing the basilar invagination. The odontoid is already into the skull. The brainstem is hanging over. There's severe compression. Now we've lifted the skull off and used this plate and screws to keep that relationship separate. Contemporaneously, our method now is to screen everybody with severe scoliosis for basilar invagination. So this is a girl who came in with a very severe scoliosis of 86 degrees. And when we screened her for VI, she had the VI. So we treated the basilar invagination first and then took care of her scoliosis. And you can see that she has a plate and screws very similar to that other boy to stabilize her basilar invagination. This is her clinical photo showing the severe scoliosis. And I show this to you because scoliosis is readily apparent on a physical exam, but basilar invagination may not be diagnosed just on physical exam except for some of those signs. So we did an MRI scan prior to the scoliosis surgery and found the BI. So this is her MRI scan showing the severe basilar invagination and the syrinx from the CSF, cerebrospinal fluid flow obstruction. We did traction, and you can see how very nicely the skull lifted off the cervical spine. We then stabilized her with a plate, and we also put a shunt to take care of that excess fluid on the spinal cord. And these are just some x-rays from the surgery. And you can see how nicely the MRI shows resolution of the basilar invagination and the syrinx. And we were quite, the surgery was quite successful. And then, as a second stage, many months later, we took care of her scoliosis. And now she's sitting straight, and all of the symptoms from the basilar invagination have resolved. So this is a previous x-ray you saw with the platabasia and the severe impression, and you can see this is the MRI that goes along with that. We had some technical issues. Oh, thank you. And here you can see the MRI view showing the syrinx and some of the basilar impression on the front to back part of the scan, and how the cranium settles on the cervical spine. What we've also described is if the children are very small and we don't have available instrumentation for them, we've described another technique for an occipital cervical fusion where you can use some bone in exchange for the plate and use wires, such as I've illustrated here. And this technique is especially applicable for small children. So traction forms the mainstay of the indirect decompression, and we use that technique of the bone graft and wires to treat this patient very successfully. So what are the outcomes? How successful is this surgery? Fortunately, we can get a fusion almost all of the time, but sometimes if you follow these patients out for longer periods, the settling will reoccur. It's just hard to get the bone to be strong enough to support the weight. But the minority of patients have recurrence of symptoms after many, many years. And there's, as I said before, no improved results or decreased rates with bisphosphonate treatment. So although we still recommend bisphosphonate treatment for the spine and the extremities, we can't say that bisphosphonate treatment is very effective in preventing BI or alleviating the symptoms. So for symptomatic patients, surgery is effective, but they need to be followed long-term to see if the symptoms recur. So we can halt progression of the symptoms before the nerves become very weak. We can improve the syrinx or CSF flow, and we can improve what the skull and cervical spine parameters are on the X-ray and on the MRI. And obviously treating their scoliosis, if they have it, can improve their function, mobility, and sitting tolerance, and most importantly, improve their pulmonary function. And with our scoliosis patients, we've had, fortunately, no reoperations, readmissions, or complications in the major or severe category. I think it's important to recognize the symptoms or progression of these conditions early. That way the surgery can be more successful and the complication rate can be reduced. So I just want to recognize my team at the Alfred DuPont Hospital for Children and Nemours Foundation. We have a multidisciplinary osteogenesis imperfecta team ready to take care of even the most complicated problems in Wilmington, Delaware. Thank you very much for your time.
Thank you very much for your time. We have time for one, maybe two questions. You mentioned this is, of course, a very severe condition when you have symptoms. How often should you follow up someone who has been diagnosed with BI? And in what way? Should you take new scans, or should you just watch the symptoms?
I think you can watch the symptoms. So perhaps every year or every other year, you can screen them for new symptoms and record that in the chart. But I think education for the patient is very important. Share with them what are the signs, what are the symptoms, and if you develop these symptoms, come back sooner. Now, if they have a scan showing BI, but they don't have symptoms, we can watch and wait. If they develop symptoms on top of that, then I would recommend that they consider treatment before the condition gets too severe.
So one of the problems is that we don't have that many doctors in Europe who knows about this, or who can perform these surgeries. Or so if you have the diagnosis, who should you be seeing? A spine surgeon or a neurologist? Or what is your advice on that?
Well, I think that any physician that you're seeing for OI, even your primary care physician, can obtain knowledge about the symptoms and order an MRI scan if there's a concern, right? Now, once you have the scan, a radiologist can diagnose basilar invagination just by those parameters that Jana and I had outlined. If you have the diagnosis based on the MRI, I would recommend you see a neurologist, and that's a doctor who can examine the nerves, but they don't do surgery. They may be able to direct you to a spine surgeon. A neurosurgeon or a orthopedic spine surgeon who has experience treating craniocervical anomalies are the two folks that could actually do the surgery.
And one very short final question. When you talk about BI, do you then talk about basilar impression and basilar invagination like a one concept? Because there is a lot of confusion about this.
Yeah, I know. Unfortunately, I think that abbreviation has encompassed many different terms. So I like to reserve BI for basilar invagination, the most severe form of the three things that we had outlined: platybasia, basilar impression, basilar invagination, in order of increasing severity. So I guess if you're given a diagnosis of BI, it may not be very severe. Just confirm with your doctor which one you actually have.
And that was everything we had time for today. So I thank you very, very much for taking the time to do this talk. I think it's a topic that needs more knowledge in the whole world. So have a nice day, and thank you very much.
Okay. Thank you very much, Imogen. Thank you very much. Have a great meeting.